Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can thrive, be profitable, and successful for years to come. I'm very excited today about our topic of discussion, which is right in my wheelhouse, and I could talk about this for days on to end. So we're talking about revenue cycle management, and we really haven't focused on this side of healthcare consulting yet on the podcast. So we are excited to speak to the medical and dental practices out there and give you tips on how to really improve your processes under the revenue cycle management space, so that you're not losing step with your reimbursement efforts and that you're ahead of the curve when new information is published as coding or billing guidance that could affect your practice. Now, I'm excited today because with me to tackle this topic, I welcome fellow NSCHBC member Misty Haralson, who is the founder of Medical AR Services, LLC, a U.S.-based billing company, bringing almost 15 years of full revenue cycle management experience to the table. And Misty is also a CPC, COC, and CPMA. We both have alphabet soup after our names, so it's always fun. Misty has extensive experience in detailed analysis of claims for appropriate reimbursement and appealing claims in multi-specialties. Also, our NSCHBC member Vinny and Vinod Sankaran, CEO, founder of Medical Billing Wholesalers, who also brings 15 years of experience in operations, financial analysis, strategic planning, and marketing. And also at Medical Billing Wholesalers, he's involved in applying his experience to optimize revenue cycle processes through process flows to improve client profitability and performance. And then there's, of course, me, your host, and my company, Terry Fletcher Consulting Incorporated. We focus on specialty coding, billing, auditing, education in the RCM space, and I'm going on 32 years in the field. So I'm not feeling like the youngster here right now, girls and boys. So I'm just saying this is going to be fun. But I'm just so proud to have these subject matter experts with me today, and to have the roundtable discussion to really find those pain points of medical practices and hopefully arm you with some tips of the trade to ease your workflow processes in the revenue cycle management space. So Vinny and Misty, welcome to the podcast.
Thank you, Terry. It's great to be here.
Thank you so much, Terry. It's a pleasure.
So let's get it started off with, I like to look at since it is a cycle, the RCM, and we used to call it just medical billing, and then we'd get into medical coding, and then we get into medical collections. But the RCM acronym of revenue cycle management kind of took hold, I would say probably 10 years ago, because I'd actually never heard of it before, as far as explaining what we do that way until about 10, 15 years ago. So let's start kind of when the patient walks in the door and how we can improve those flows, and talking about verification, patient eligibility, because one of the things that I've noticed is that denials kind of come from inefficiencies when it comes to verifying patient status, patient benefits, patient eligibility. And I've noticed in the hospital space, some hospitals don't even check eligibility until after the patient's left. And I understand that when it's emergent, but now with the No Surprise Act, they have to be a little bit more efficient. So I'm going to throw this first one over to you, Vinny, and just, talk to me about in your kind of space and in your employees that I know you have billing companies and service and employees that work in the billing service area. How do you get this to be proficient for practices, since you're on the third party side?
So this is something we've been seeing for many years, but after the Affordable Care Act, or the Obamacare as people call it, we're seeing it a lot more because patient deductibles and copays were very low before. So doctor practices didn't care too much about the patient balance. And I'll talk about hospitals in a minute. So patient eligibility verification was not taken that seriously. Let's talk about 7, 8 years ago. Recently, it's become a very, very important thing. And usually practices don't know how to do it, or they don't have the manpower to do it. And usually it's left for the last minute. And then, something else comes up, or a patient walks in, then they forget. So we have been able to take that and do it. As a company, we've helped a lot of practices do that. Two things, right? One is we need all the data to be able to do the verification. Many times you can do it online, which makes the process much easier. We can also automate it, it helps, but many times you end up calling the insurance companies to make sure that you do the eligibility verification, especially if it is out of network. So we see that a lot and we do it. In terms of hospitals, you're absolutely right, because I just had this actually personal experience. My wife was in the hospital to have a procedure and they didn't check anything. And it's been almost 3 months and I just started getting some bills. So it is a problem. I think if we address it head on and tell the practices this is very important, it's as important as scheduling. So you want to do it 2-3 days in advance if you can. I'm not talking about urgent cares here. If you can do that, that'll really help. I think that's something that we as consultants, as experts should inform our clients to take it seriously, or we should be the ones to help them do that.
And I couldn't agree with you more. And Misty, let me ask you something. Since both of you own billing services, one of the things that I would find very challenging, and Misty, you can speak to this, is when, like Vinny said, that isn't done either prior to the encounter or prior to the visit or prior to the procedure. How hard is it for a third-party billing company to get that information after the fact?
I really use the payer portals. I think having access to that is extremely recommended when it comes to that, that it's right there at your fingertips to be able to pull all that eligibility information. And I also agree with being prepared, prior to that day. Also utilizing your EHR or your RCM software. I think there's a lot of capabilities in them. And I think being able to see what your subscription, what you're paying for in the software, and see if they have that capability to verify that information as well.
Actually, you brought up a really good point, and I know, Vinny, you could speak to this too. Are payers up to date in for the most part, in what happens as far as you said you went to their portal once you get the patient information? How up to date are they? I know the No Surprise Act says they have to be up to date, but let's face it, there's not enough people in the universe to police every insurance company. So if you don't get that from the practices that are, sending the patient over to you, how updated, and I'll send this to you, Vinny, how updated are those portals?
It's a hit or miss.
Is
it could be all over the place. Some of them are really good. And also that depends on states, because we handle the whole country. So we see some good insurance companies in California, the same insurance company are really bad in Florida or Texas. And it's all over the place, especially when it comes to out of network. When we see, it's even worse. And you always have to call the insurance company to get it. And then it's the whole time. And then you go through the whole benefits. But it has gotten better. You also have to look at the positives. And like Misty said, payer portals have become better. There's a lot of EMR system that actually give you a module. You have to pay for it usually, or they integrate with a third-party solution that helps with patient eligibility. Some of them are almost real time, and it helps. So we've seen some practices where 70-75% can be almost automated with a click of a button, and that's been really helpful in making our team more efficient, and they can focus on the remaining 25-30% where we actually have to call or get more information. And we see that a lot with surgery centers. Many times those are not enough. We still have to call, and sometimes you have to add in a prior authorization, which complicates it even more. So that's kind of where we're seeing.
Yeah, that's true. Yeah, I didn't even think about the surgery center aspect of that, but you're absolutely correct. And Misty, just a tip out there, since we're giving tips to our listeners, how do you feel like there needs to be some kind of a go-between between the practice and the billing company, kind of a facilitator to make sure you're not calling and trying to get anybody to help you?
I think open communication is very important between, the billing company and the office. I think if everybody works together, things go a lot smoothly. So I think open communication for sure.
Right. Well, the one thing too is I'm noticing that some of these simple errors can create definitely a negative impact. And one of the things I've noticed on the most recent patient satisfaction surveys with the payers is you look at, they give them usually 10 to 15 questions, and the question about how do you like your doctor is like question number 11. Now they first talked about, the front desk and your experience in wait times, and do they have telehealth, and billing actually comes up. How was the ease in the process of your insurance? So just to our listeners out there, that are involved in this space, or your practices, make sure, or your hospital, make sure that your staff understands how important it is to get this correct the first time, and to hopefully, you're still taking copies of cards and making sure that you're getting that information prior to the encounter. I couldn't agree more with Vinny and Misty, is that prior to the encounter is really important, because a patient shows up, are you willing to turn them away if they don't have the information in front of them? So this is where you've got to be proactive when it comes to that patient information, as far as from the insurance space there. So let me move on to some things that have happened in billing errors. And I know, again, we talk about that with patient satisfaction, but billing errors are tough, because I've got some saying, well, it's the doctor, some saying it's the staff, some saying it's the payer, and we just, everybody has to work together, as Misty was saying, even with eligibility. But sometimes the billing errors can happen when information is incorrectly added to the patient's profile. Even the CPT codes or ICD-10 codes are added incorrectly. Modifiers, oh my gosh, the denials I see on modifiers is crazy. For example, the 59 modifier versus the X modifiers. You need to know your payers. Some payers don't recognize the X modifiers, some do, and also know that what the payers will allow or pay for, or where the edits are. I know we talk about Medicare a lot, and that's really my space, and Medicare has a pretty clear set of guidelines for things. But then you get into commercial plans, and I'll throw this back over to you, Misty. Don't you have to have some kind of, basically, I don't want to say a grid, but a good follow-up plan, and something that you have in writing, knowing what multiple payers do, because nobody's consistent?
Yes, I agree with that. I think being educated on, like Vinny had said earlier, your states, if you're dealing with, multiple companies, providers' offices, knowing that state, having that grid of what state accepts what, or what payer in that state accepts what. Knowing your way around the payer websites, I think, is extremely important. I love to research stuff. So anytime I'm on the payer website, I'm really getting to know where to find that information. So in the case there are the billing errors, I can go straight to that payer website, and I can find, where that information is for that billing error.
Yeah, and I found, for example, and I'll just throw out the telehealth information. Oh my goodness. So we've got Medicare and everybody else during the public health emergency. But for those of you that are even interested or considering being a part of the National Society of Healthcare Business Consultants, one of our billing professionals, Cindy Walker, she's been putting together this spreadsheet on all of the payers out there and what their plans are doing for telehealth, and when things have been waived, when things have expired. And she started with 3 pages, and now it's up to, I think, 40. It's ridiculous. And it's crazy to me to think that there should be somebody that's, almost in charge of just doing that research. And don't assume that, and this is, and actually, Vinny, I'm going to throw this over to you. Don't assume that the billing company you're using is actually doing the research. You've got 2 experts here that they do it for their company, but you will find some companies that don't do this research. They're basically data entry people. And Vinny, I'll speak, or let you speak to that, because I see that every once in a while. Do you?
Absolutely. We do. So we actually help a lot of different kinds of companies, practices, health systems, hospitals, but also billing companies. And many times we see that. So in terms of what you said, I agree with what you and Misty said. We have to know the rules, right? Each payer is different and it changes. It's not like it's, you have it now and they're not going to change anything for 3 years. It doesn't work like that, right? They can change it, especially with the public health emergency. A lot of changes happen. Like you said, I've seen what Cindy Walker put out, and it keeps adding. It's definitely over 40 pages now, and each state is different, and it keeps changing. Yeah, it's crazy, right? So we started document everything. We call it cheat sheets. So we work with multiple EMR systems and obviously different payers, Medicare, Medicaid, and commercials. So we try to make our employees like subject matter experts when they work on AR. So you are in charge of 3 EMR practice management systems and these 3 commercial payers. It becomes easier to handle. because you can't give everybody the rule for everything. It's just impossible. We used to document it, and now we have something called the workflow platform. We call it the MBW Hub. We actually put it so as they're working, they can look at it in the dual screen. If they have any questions, they just refer to it. It's still a work in progress because you have to update it constantly. And, we have a team just to do that. Even then, it's overwhelming.
Right. No, I think that's a great idea. One of the things I did change, I do depositions every once in a while, and I changed the term cheat sheet to reference guide because the attorneys love to jump on that. So just a little tidbit there. Change it to reference guide or reference tool because they're like, well, who are you trying to cheat? Like, no, you don't understand. It's just a shortcut. But so I definitely a couple years ago went, okay, reference guide, reference tool. So those of you out there, I know everybody uses them. Make sure that you just change your label for it because it definitely can come back on you at some point. But one of the things that we were talking about, as far as patient eligibility and verifying coverages and now looking at billing errors. When Vinny and Misty and I were talking, when we talk about billing errors, we're not just talking about inputting information or just the ICD-10 or CPT codes or coverages. Here's a big one that has come up for me, and I'm not even in the dental space. So if you are a dentist out there, I know we do have some dentists that are listening to our podcast, and you also perform oral surgery. You don't put that under the dental part of the patient's coverage. You put it under their medical part on their patient's coverage, or you're taking about a 50% reduction because it's covered on both sides. But as soon as you get into oral surgery, you're now in the space of just like a surgeon, a general surgeon. And a lot of practices had no idea. And I was actually doing an audit for this one practice. And I said, well, I'm not in the dental space, but he's like, well, I just want to use you. I'm like, okay, well, I appreciate that. I've got somebody I can refer you to, but let's look at it. And now apparently I'm in a little bit of the dental space, but I was noticing the oral surgery and I'm just like, why aren't you putting this on surgery? Look at the differences in coverages. And this poor, dentist, he had no idea. He just said, oh my gosh, I'm certified in oral surgery and I've been taking a 50% hit forever. And then I had another one where I had a practice that they basically came to me for a question. And I said, okay, and I want to say this, I guess in the most respectful way, because we have listeners out there and I don't want to say anybody doesn't, know what they're doing or understand certain things. But when you engage, whether it be a billing service or you have your billing in-house or whatever you're doing, make sure not only that you have certified people, but you have people that understand your specialty. I'm getting a lot of, one of my main specialties is cardiology, and I'll get these questions that should be routine to the person that understands the specialty. And Misty, I'll throw this to you. You probably have heard this too, where somebody will say, okay, well, I want to bill a heart cath with an intervention, a stenting or an angioplasty, and the payer never pays for it. I'm like, well, never's a long time. And they say, well, we just write off the heart cath. I'm like, oh, no. So is it diagnostic? You have to know what that means. Is it routine or setting up the information? And so, Misty, do you see that in some of the specialties that, you're billing out for, that you can tell that who's ever coding it is not familiar with the specialty?
Yes, for sure. I think knowing, where to go to get your information, have everything on hand, all your NCCI edits, all the guidelines. I use Medicare, all the time for like a foundation when I'm, coding. So I think having all of that rightly available is good practice.
It is. And Misty brought up a really good point. We call Medicare kind of the gold standard. That's kind of where we start. And then other payers will have some contract information or, they will have some things that they'll put out for specific specialties. But when they don't have anything, and just what's coming to mind is like the Incident 2 rules with nurse practitioners, I try to use a standard that I know I have published guidance. And that way, if they want to know why we're doing something a certain way, even though I'm talking about a Blue Cross plan or an Aetna plan, it's because I have published guidance from the federal government. And if they do it this way, I would think that I'm probably erring on the conservative side, and we'd be able to support it if we ever, have that looked at. But moving on forward and talking about some of the pain points and the errors and things, I'm finding that this kind of leads to, and I say this with kind of empathy for anybody out there that is in the revenue cycle management space. It's a lack of training. I think that there's an expectation that even coders are supposed to have the clinical knowledge of a physician, and that's not fair. Understanding, again, the specialty that you've now been hired to do the work for, understanding, we're in a PHE versus we're not, when you're not in that space, understanding the EMR. I'm finding that the lack of training is almost setting up certain staff to fail. And this may be why, if you have it in-house and you're finding that your collections aren't there, I would, I always like to keep it in-house, but there are times when I think it's important to sub it out and outsource, but you have to also make sure that those services are with people who are trained. And Vinny, I'll send that one over to you when it comes to training and making sure that everyone's updated on new codes, not just CPT, but ICD-10, HCPCS, because remember, you both have been in this space forever. Remember how CPT only updated once a year? And now you're noticing, especially with the vaccines, they're updating, seems like every quarter, every week.
Right. It was once a year. That's what it was for many, many years.
Yeah.
I mean, I'm not a coder. I know both of you are, so I'm not going to dive too much into coding, but we have a whole team and everybody is certified in multiple names after their name, just like the both of you. And they keep reading all the time. And they tell me that things are constantly changing. I see it in our listserv. We see all these emails. Some I understand, some I don't. If it gets really technical in coding, I back away and let the experts handle it. But I'm seeing, so in terms of training, you're absolutely right. Like I mentioned before, training is very important. So you can't train everybody on everything, right? So when you mentioned something about dental space, so we don't handle dental and eye stuff. But when it falls in the medical side, we will. And we've seen a lot of dentists do exactly what you said before. So the medical, so everything is about training. It starts from the doctor's office, front office staff, and then to the RCM staff, which is kind of what we do. So we have really like in-school training. So we train them on the basics and then whatever they're going to do. And before we start with any client, we have to discuss the scope of work. What are they responsible for? What is our team responsible for? And what we can and we can't do. There are some things that we need an okay from the doctor, so that's on them. And other things we can do, like in denials, following up, coding, appeals, a lot of things that we do on a daily basis. We become much more efficient than the practice because they're handling 1 and 2 a month. We're doing hundreds a month. So it makes it. So training is very, very important, be it on the procedure process flow, be it the EMR practice management system, the payer rules, everything comes down to training and, knowledge.
Yes, it does. And you actually brought up something kind of interesting when it comes to training. So, when we talk about training, we're not just saying how to code. We're not just saying, how to procedural code CPT or how to capture ICD-10 codes. That, even though that is very important because that translates from what the providers have done, what the hospitals have done, what the facilities done into billable services. But there's also pieces of the revenue cycle management and that in that department that requires training for compliance. There's regulations that change frequently. There's policy updates with payers that change frequently. And I really like what, Vinny said, where he has people that are in charge of certain payers. I actually was talking to a practice recently and they don't have an EMR. They're still on paper. My head almost exploded. I can see Misty's head's exploding even though I can't see her right now, but it was still on paper and they were on the East Coast. And basically they were getting denials and getting requests for records because they had illegibility issues. And I just haven't seen that in 20 years because of EMR, EHR services. But the other thing that I get a lot is that people are getting their information off Facebook. They're saying, well, I get my codes off Facebook. I just put it out there to a coding person. And I'm like, oh boy. Wow. And do you see that, Vinny? I mean, I even had somebody saying that, well, my doctor won't buy me my code books. And so I'm using something from 2015. And I don't know if either of you see that, but Vinny, I'll send it to you first. And then Misty, I'll have you follow up there.
Sure. I have seen it a couple of times, not mostly from the staff, but some doctors are The doctors who think they know everything, sometimes there is a problem because they want to do the coding. Everything should flow to them. They kind of the micromanagers. So sometimes I've seen that over the years, not as much, but I have seen it a couple of times, and they don't update their books. They're like, we have a book. What's going to change is the same human body. That's their approach to it, and that's a problem.
That is a problem. And Misty, have you ever gotten, charges or anything from one of your clients, and then all of a sudden you're looking it up in your CPT book that's current, by the way, and you're like, wait a minute, that code doesn't exist anymore?
Yes, absolutely. And even ICD-10 codes, the claim will deny, and it's like, well, it's an old diagnosis code. So yes, I've definitely seen that.
Yeah, it's like, okay, well, did you know that this code got an extra digit 3 years ago? I actually had one recently, and this was actually kind of scary to me, where I had a practice and it was a new administrator, and they just kind of cleaned house, and the staff basically said something like, well, we're trying to get our consults paid to Medicare, and Medicare's not paying them. I'm like, well, in 2010, Medicare stopped paying or recognizing consult codes. And I was like, wow, this is 2022. So what our basically our message is here is you have to train your staff, be updated. And staff includes physicians. We love our doctors because obviously we wouldn't have jobs without them, but make sure you also give them the tools, the updated code books, the policy information if they're asking for it. Even if they're not, send out a memo. Make sure that, they understand that. And then I want to move on a little bit because we could talk about, aerosol forever. But one of the things that also needs to be updated, and this is where Vinny impresses me because I am not IT savvy. I can get by. I understand the certain things in the information technology space, but there's a lot of IT now that is part of the patient experience. I mean, we've got robotic surgeries, we've got electronic health records, and now they're even trying to I noticed a lot more doing a computer-assisted coding, financial arrangements. A lot of that is just through the IT process. So when you have an outdated system from IT, or you're not updating or getting your updates, even for your EMR, how does that affect people, Vinny? I know that's a problem as well right now.
Yes, it is, Eddie. So what do you want? Technology is growing pretty fast. 10, 12 years ago, we didn't have EMRs, right? A lot of paper, they were scanned. I remember billing companies used to go and physically pick up the papers. There was fax, then it became email. EMRs changed a lot of that, right? So with that, you're saying from the patient side, the doctors are using robotics to help them with surgery, which is great. I got my LASIK surgery. It was totally automated. It was kind of creepy, but that's how it happened. And I've been wearing glasses. I've been wearing glasses for 12 years. I haven't worn glasses in 12 years, so that was good. So in terms, and it's moved on, right? Every different one. So a lot of doctor practices using, automatic check-in. They give you an iPad. You can do it in your house, or when you walk in, instead of papers, just all your stuff, privacy statements. Anything that you need to sign, you can do it on an iPad. That way, there's no paper. It's much easier, things like that. Also, on the RCM side, with EMRs, there's a lot of third-party integrations. I just spoke about RPA and AI in revenue cycle, and it's picking up a lot. We are actually working with a bunch of AI-based coding companies, and they're doing a pretty decent job. So I would say about 65-70% of, I'm talking about hospital emergency department coding and stuff, are automated by AI, and we just have somebody review it, and 99% they are great. The 30-35% that gets kicked out is done by a human. So we are seeing a lot of technology in this space, and with this, cybersecurity is also very, very important, because as technology improves, there's always somebody going to try to hack, and there's going to be a breach and data breach. So both come side by side. There's a lot of protection you need to make sure that doesn't happen, because once something like that happens and you're in the news, you lose credibility, be it a billing company, be it a hospital, a practice. Data is sacrosanct, and you need to keep it safe.
That's true. And you actually brought up a really good point. When the reason I brought up IT is because I think sometimes IT moves so much faster than medicine does sometimes. And so we really have to kind of keep up with the Joneses, if you will, you know, in the IT space, but also making sure that you can interface with certain systems as well. You know, right now there's a big controversy on prior authorization. Now, I know, Misty, you probably deal with that a lot with the pre-authorizations, and you're waiting for that to happen and just not getting there because of certain IT, you know, incompatibilities.
Yeah, I would like to add, you know, doing your due diligence on acquiring a software, make sure that it can handle all of your office duties, and if they're legit. A lot of the EMR, EHR systems are delivering on a promise that's not delivered. So, for example, accuracy on claim submissions or capabilities of the system, or even the privacy and security with HIPAA. So I think just doing your due diligence on, you know, the progression to the IT department is a good idea.
Yeah, and you brought up a really good point. You know, really make sure that if you've purchased an IT system, if you purchased an EMR, you know, hold them to the contract, hold them to what they promise that they will do. Now, I just want to kind of wrap this up in the kind of, not the final part of RCM, because I know we've kind of taken it through the cycle, but, you know, when we talk about denials on the back end, who's handling that? One of the things I love that Vinny said, and Misty agreed, was that you need to have experts in the payer. You really do. I'm still seeing practices that are telling staff, well, you handle, you know, A through D, and you handle, you know, E through L, and that's not the way to do it. You need to have experts in the payer, because if a physician comes back to you and says, hey, is this covered, and it's a Blue Cross plan, they know the point person to go to. It's not being an expert in what every single different patient is, and our volumes have increased. It's what a particular payer does, because now you know how to handle a denial. And I know that we are doing everything electronically and trying to really integrate a lot of things in the digital space, but you also need to make sure that if you've sent a denial reconsideration letter or anything like that, that you've taken a copy of it, that you have it in a compliance manual or something, so you're not reinventing the wheel every time. And a lot of time there are some manual efforts there, but you know, patients are now requesting cost estimates, you know, under the No Surprise Act, and we have to make sure that we can tackle not just denials but authorizations and a lot of things that we're doing on the back end. And these are high volume transactions with people who are specifically tasked with the denial management. And, you know, that's something that I'm seeing, that there isn't somebody that wants to handle it. It seems like they're like, no, you do it. No, you do it. And, you know, Vinny, how do you handle that within your staff?
That's a great question, Terry. So many times, I'll just start with the practices and come back to what we do. So many of times the practices, right? A person in the office is doing multiple things. There's a doctor asking them something, they're on the phone, there's a patient standing right in front of them, and they have to follow up on denials or call the insurance company. It's not all possible. And like you said, you know, patients, especially in hospitals, are asking for cost estimates. So their workload has just gone up. And with everything that is going on with labor shortage and remote work, nobody actually wants to work face to face. It's getting much tougher. So a lot of them, even if they have a in-house billing team in hospitals or large practices, it's great that they talk to a billing company who can help them and be like an extension of their team. So if they have 5-10 people doing billing, but they need actually 15-20, talk to a company. They can help. There's a lot of companies that can help them clean up. So in our case, we have like silos. Each department is split. We have coding departments, and they are split by specialties, right? You can be an expert on all specialties. As coders, you both already know that. So similarly, we have the charge entry team, payment posting, denial team, AR follow. One team only follows up on the website, and the other one only does phone calls. That way we make it more efficient. And then we have the hub, which tracks everything. So there's IT involved, and there's a lot of tracking, and there's quality control on the side to check to make sure that everybody is doing their productivity and quality as needed. So everything has to move together. And if it doesn't, trust me, the clients call us and tell us, so we know.
You definitely get that yelling from the background. Yes, exactly.
Yes.
Yeah, no, I can understand that. And Misty, to you, do you have the same processes or similar to what Vinny was saying?
Yes, it's pretty much the exact same thing. I mean, I I would say, like, invest in your RCM department. Make sure that everybody knows, what their job description is, what they should be focusing on, where to go to get the information, because the denials are your last chance to receive the reimbursement, and you want trained and educated staff handling this. I have some specialties, but I love general surgery. That is my absolute favorite specialty. And you ask me really anything on general surgery, and I can kind of, spit it out and say, this is why it denied. And knowing your denial reasons, know what the remark code says, having an EHR system. I've worked through a lot of EHR systems, and there's some that are very, very simple, and you have to go search for the EOD and find this. And it's a lot easier when you have an EHR system that has everything right at your fingertips, to have that denial reason detailed out with the remark code, to know what my next step is to do the denial process or send an appeal.
Right. And I agree with you. I'm noticing too that many practices are investing in, the electronic health record, but not the management system side of it. And you really have to make sure you've got a good system there, because this is your reimbursement. This is your bottom line, and it's just so important. And what I'm seeing, I just saw a post recently on LinkedIn, I think it was yesterday. Vinny brought up the thing about remote working. It's not just the staff, your staff, the medical staff, and the billing staff or your central billing office. It's the payer staff. I saw two companies. One was United Healthcare, and I don't remember the other one, but it was another payer. But they basically said, we're letting our leases go on 2/3 of our brick and mortar, services, so that we can have our staff be all remote. Well, try to get a hold of a payer nowadays, and it's really tough. And so it's really important to have a dedicated person that's really working on these as well, and they understand that payer, because getting a hold of them when they were in the office was one thing, but now they're remote too. And I remember I was calling a payer doing a denial for a client, and I heard the barking dog and the baby in the background, and then the payer finally said, she goes, I don't have time for this right now, and just hung up on me. And I was like, you've got to be kidding me. This is a payer. So, wow. Do you see that, Vinny, every once in a while?
Yes.
Oh,
We see
gosh.
that in multiple stuff. So we do a lot of credentialing follow-up for companies that, handle it, and the follow-up calls. So everything that was taking 45, 60 days is taking 90 plus days for the same reason, because they are remote and they're not getting back to us. Many times we can't reach the people, but it's also with other things. When we call up for denials, the hold times, which are 15, 20 minutes, is becoming 40, 45 minutes. And that is if you're lucky to get somebody. See, before, if you were nice and you talk to them, instead of giving you status on 3 claims, they would give you 6 and 10. Nowadays, to just get them is tough, and they're not in a good mood. It's changed a lot over the last 2 years, and not for the better, especially from the payer side. They're making a lot more money by not having these offices and leases, letting them work remote. Their employees are happy, but they're not as productive. Even before, they were not very productive. Now it's worse.
It is a mess, and I agree. And that's why, again, going back to that IT information, what Misty was talking about too, and what Vinny agreed with, is making sure you're also utilizing their websites, utilizing the information that you can get from, an IT perspective. Well, I'm going to go ahead and wrap this up, and just to kind of recap here, just make sure when we're talking about the revenue cycle management that you have people that understand the eligibility process, that there's somebody there that knows how to make sure that they're verifying what the patient's benefit and eligibility is prior to coming in. Billing errors, watch those simple errors, just in data entry, in coding errors, just making sure that, incomplete documentation, that can lead to a large number of claim denials, and you really want to make sure that you're not in that space. Understanding, the coverage, like I mentioned, the dental versus the surgical, or understanding the specialty is important. Train your staff. You need to train your staff, and lack of training can definitely lead to more erroneous information being put into your system. Make sure you're updated on your IT, and then have experts in the revenue cycle management space. Make sure you've got somebody that knows about a certain payer, that knows how to handle a denial, because that'll, you're going to need that in the future, and those are the people that you're going to need to continue to rely on. So I would like to thank both Misty Haralson and Vinny Sankaran for their expertise today and joining me on our Revenue Cycle Management Roundtable discussion. Listeners, I hope you found it helpful. You can find Vinny or Misty and their contact information on the NSCHBC website at Find a Consultant. You can just type in a first name. You can find me there as well. And it just comes up for you. So we hope that you reach out if you have any questions or need services in this space. We'd be happy to help you. So that's it for us today, everyone. Please join me next month when I speak with fellow NSCHBC member Mark Lyon on physician and dental retirement planning. And now it's really time to start planning for the future. So until next time, I'm Terry Fletcher. Everyone, make it a great day and a great rest of your month. And thank you for listening to the NSCHBC Edge Podcast.
Thank you for listening to the NSCHBC Edge Podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.